Welcome everyone again to the Nutrition for Growth official side event on infant feeding in emergencies, learnings from other countries' experiences. My name is Linda Shakat Berbari. I'm a consultant with the Emergency Nutrition Network and the Infant Feeding in Emergencies Core Group Facilitator. I'm happy to be here with you alongside my colleagues and a colleague from Mrs. Hiroko Hongo. This side event is organized by the IFE Core Group, or Infant Feeding in Emergencies Core Group, Safely Fed Canada, Alive and Thrive, and Infant and Young Child Feeding Support Network in Japan. We are grateful for the support of the Emergency Nutrition Network, La Leche League Japan, the Japanese Association of Lactation Consultants, Breastfeeding Support Network of Japan, and Save the Children Japan. The duration of this side event is around 90 minutes, and we're really looking forward to this exciting side event on the occasion of the Nutrition for Growth Summit. As we are starting, please feel free to introduce yourselves and where you're coming from in the chat box. I will hand over to Hiroko for also her introduction. Hiroko?
Okay, my name is, I'm sorry. Thank you. I'm sorry. My name is Hiroko Hongo, chair of Hahatoko no Ikuji Network, IYCF Support Network in Japan, and a member of IFE Core Group. I'm Japanese living in Tokyo. I'm sorry, I put video on. And using this occasion, I plan to organize this side event in collaboration with other panelists and organizations. English and Japanese simultaneous translation is made possible with the support from the Save the Children Japan. So please choose English language after clicking the interpretation icon if you would like to listen to in English, and all the panelists need to choose English. Hi.
Thank you so much, Hiroko. If you allow me just a few words about the IFE Core Group. The IFE Core Group is a global collaboration of agencies and individuals committed to the protection, promotion, and support of infant and young child feeding in emergencies. You can see the members of the IFE Core Group on the slide. The IFE Core Group is hosted by ENN. It is part of the Global Nutrition Cluster Technical Alliance, and we are grateful for the support of the members of the IFE Core Group, as well as that of USAID and Irish Aid. One of the main outputs of the IFE Core Group is the development of the operational guidance on infant and young child feeding in emergencies, that yellow book that you see here. It provides guidance on how to support, promote, and protect IYCF during emergency settings. You can see on the slide some examples of interventions in emergencies. First, to protect infant and young child feeding by abiding by the International Code of Marketing of Breast Milk Substitutes and subsequent resolutions, to promote recommended infant and young child feeding practices through education, counseling, and to support all mothers and caregivers to provide adequate infant and young child feeding in emergencies. During emergencies, ensuring that infants are exclusively breastfed for the first 6 months and that breastfeeding is continued for the first 2 years or more with age-appropriate, adequate, and safe complementary feeding is crucial in safeguarding the health of infants and young children. It is a life-saving intervention. It is not, however, easy to ensure this support. Before I hand over to our global experts to really tell us about lessons learned in infant and young child feeding in emergencies, I'd like to ask you to please answer this poll. So you will have a poll that is in front of you. If you could please answer it. Have you ever provided infant feeding support during an emergency? If you could tell us whether you have done so, and then we can see your experience in terms of providing support for infants and young children during the emergency. I can see already about 100 participants, and We will wait for a few seconds more until it is about 47, and then we will close the poll and see the results. I think we can close the poll now. You can see that 22% of the participants have provided infant feeding support and 78% have not. So we really hope that this webinar will provide you with some ideas and really encourage you to provide this support. So we'll close the poll now. So to share with us their valuable experiences and learning related to infant and young child feeding in emergencies, our speakers today are global experts in the field of infant feeding in emergencies, Mr. Alessandro Ilamo, Mr. Paul Zambrano, Dr. Carleen Ribble, and Mrs. Jodine Chase, whom I'm delighted to present subsequently as we move with the webinar. So our first speaker, without further ado, I'm really delighted to present to you a colleague and a member of the IFE core group, Alessandro Ilamo, who will speak to you about infant and young child feeding in emergencies as a global priority. Alessandro is a senior emergency nutrition advisor for FHI 360. He has extensive expertise in infant and young child feeding policies and practices, particularly in emergencies, and the WHO International Code and other global tools. He's worked with the WHO's scientific and technical advisory group on the international code and assisted the International Baby Food Action Network with the development of the World Breastfeeding Trends Initiative and IYCF policy tools. He has been involved in research on IYCF and IYCFE and nutrition policies, practices, and programs, including work environments, international code implementation, and financial aspects of the WHO UNICEF Global Strategy on IYCF. His expertise in nutrition, emergency nutrition, and IYCF has supported humanitarian work in Africa, the Middle East, and South and Southeast Asia. Recently, he's been engaged with IYCF-related policy issues in high-income countries, including Italy, Australia, and Japan. He's led the planning, organization, and facilitation of webinars and workshops, including the latest independent dialogue hosted by the Institute for Climate and Energy Disaster Solutions and the ANU Gender Institute at the Australian National University. Alessandro, the floor is yours.
Thank you, Linda, and thank you to the colleagues, and really thank you to the organizer of this wonderful event. And more importantly, thank you to all the attendees for giving me a chance to be here with you today. So yeah, my task is just to give an initial overview on our infant and young child feeding in emergencies and why it should be or should become, if it's not yet one, a global priority. So next slide, please. Before starting, I think it's really important we are all on the same page on what we mean by recommended breastfeeding practices, or what sometimes we call optimal breastfeeding practices. This is in line with the global recommendations, the global evidence-based recommendations of WHO and UNICEF that were endorsed in 2002, so around 20 years ago, by all the member states of the United Nations. So these recommendations are basically to ensure all of us, all governments in high income, middle income, low income, should ensure that infants are at birth are immediately put skin to skin in contact with their mom and initiated breastfeeding within the first hour of life, are then exclusively breastfed, meaning receive only breast milk and no other foods or fluids or liquids during their first 6 months of life, and then continue breastfeeding up to 2 years or beyond, while complementary feeding that is safe, timely, and appropriate is introduced. So this is our aim. This is our global aim. And this was endorsed once more by all governments across the world. Next, please. But how are we doing? And these are some of the most recent figures. As you can see, we are still far from ensuring that every child is able to enjoy that that breastfeeding, is able to practice, to be supported, to meet those breastfeeding recommendations. And in particular, only less than 50% of children, based on the most recent statistics, are exclusively breastfed for 6 months. And even less than 3/4 are actually able to breastfeed for the 2 years initial recommendations. And please note that for breastfeeding, the high-income countries or the upper middle-income countries, as you can see from this graph, are those even with lower, much lower breastfeeding rates. So there is really a need to push at all levels, from low-income countries, but also including high-income countries, to improve and increase the situation in relation to breastfeeding and breastfeeding support. Next, please. If people will ask about why should we, why do we need really to improve breastfeeding practices? What is the reason? Why do we need to push our governments, or the government of Japan, or the government of any country? Well, again, evidence has shown that there are major reasons for any government in the world to invest and support breastfeeding practices at the country level. We have one major reason is that across all contexts, and I want to reiterate, across all contexts, breastfeeding can save up to 823,000 under 5 years of age children from dying. And then there are several other major reasons that include the reduction of infection-related mortality during the first 3 months of age, the prevention of around 70% or more of hospital admissions due to diarrhea, childhood diarrhea, and around 60% of hospital admissions due to acute respiratory infections. So this analysis that was conducted by the Lancet included also high-income country statistics. So this is one major reason, one of the several important reasons why we should continue advocate for more support for breastfeeding. Next, please. Beside what I mentioned in relation to the child, there are important considerations also on how breastfeeding can enhance maternal health. And again, the Lancet data show that with current rates that are still not satisfactory, we are preventing already 20,000 deaths due to breast cancer. But if we do more, if countries like our countries, Italy, Japan, Australia, Canada, if looking at the speakers of the Philippines, could just improve or increase their breastfeeding rates, we could add additional 20,000, we could prevent an additional 20,000 deaths from breast cancer. Again, the evidence that we have is definite on the fact that breastfeeding can also reduce the risk of ovarian cancer, and that breastfeeding is an effective method for birth spacing using the lactational amenorrhea method. So there are important reasons why breastfeeding is also a key maternal health intervention. Next, please. Third, there is an economic reason. Breastfeeding makes sense from an economic point of view. And again, as you can see from the table, the analysis was conducted across all contexts. And just with improving breastfeeding rates could help generate $302 billion in economic gains across the various regions. And this economic gain is mainly linked with the increase in IQ that has been associated with improved breastfeeding rates. And something that is very important for high-income countries, but for all countries in particular, in general, but in particular for high-income countries, improving breastfeeding rates will certainly have a substantial impact in the reduction of healthcare costs that we are now for example, facing. And there were some estimates for countries like the US, the UK, Brazil, and urban China. So again, we have the public health imperative, and we also have the economic imperative of why breastfeeding needs to be a priority for our governments. Next, please. Now let's look at the other aspects of it. What's our consistent challenge with breast milk substitutes, or just to simplify, with infant formula or milk formula? And I really thank Dr. Julie Smith for allowing me to use the information contained in this slide. What is our challenge? What is our issue with infant formula? There are several, as many of you may agree with me or may also disagree. And certainly, a certain type of marketing, certain type of aggressive marketing that has been documented undermines our human rights. We should never be naive, and we need to understand that marketing of these products aim at selling more products, at increasing the utilization of those products. Obviously, then marketing of those products is meant to undermine breastfeeding, no? Increasing the sale of certain products like infant formula automatically will have an impact on your breastfeeding practices. Marketing of these products undermines also the integrity of our health system. And this is something we should be conscious on how the health system in certain contexts has been exploited, no, has been used by the industry to market, no, their products. Lastly, but not the least, is its breast milk substitutes or milk formula are a challenge because eventually we need to, again, we shouldn't forget there is enough evidence and there are enough recommendations that shows that both powder milk and or the liquid form of infant formula are not sterile products at the manufacturing line. No, there is not yet a perfect product in terms of its sterility. So there are risks associated with the product. So these are some of the reasons why we need to keep in our mind that we have to have appropriate rules, regulations, systems to control or manage those issues. Next, please. And this is just an example, one study that we conducted in the Philippines that really confirmed that the more certain type of marketing of these products does affect the breastfeeding practices of a country. And I'm sure, and these similar studies have been made in other contexts and similar contexts. Next, please. Let's look then on how this translates into an emergency situation. Next, please. Well, what do we see as the challenges of breastfeeding or infant and young child feeding, focusing on an emergency? For those that are familiar, certainly may agree that displacement of families, stress, fear. What we have seen, and my colleagues later on will expound on this based on their country-specific experiences, is that there is a general lack of support for women and their infants in relation to infant feeding. At the same time, we are faced with donations of infant formula. At the same time, we've seen how companies may exploit certain emergency conditions. So the experience of Canada, for example, Japan, and I know also Australia, New Zealand, will highlight how these are the consistent and current challenges. And the COVID-19 pandemic, unfortunately, has reiterated the issue around marketing of these products as documented by WHO and UNICEF. Next, please. And this is an example on how and why we are saying that donations of certain products, of milk infant formula products, have a negative impact, may have a negative impact on the affected population, both because it disrupts breastfeeding, two, because it may have, has an impact on on child health. So in this case, for example, those families in those families that receive infant formula donations, breastfeeding was disrupted, and the rate of diarrhea among the 2-year-old children was twice high compared to those that did not receive any formula. So you can see the negative impact of donations when they are not done, or they are not following the international standards and recommendations. Next, please. So what can we do? And I think we will discuss during this webinar several ideas, several actions that we should all take. Next. Well, we have certainly a set of global policies, frameworks, and guidance. I think we are not short in what we can in global tools. And Linda earlier on mentioned the infant and young child feeding in emergency operational guidance, the yellow book, that provides that directions. We also have commitments, and in 2018, all governments, including high-income countries, committed to do whatever is necessary to protect breastfeeding during emergencies. And this is the 2018 World Health Assembly resolution, and this is an excerpt from that resolution. So we have tools, we have guidance that, if implemented, can bring us to provide appropriate support and protection to breastfeeding and infant feeding in emergencies. Next. But how are we doing? And this is one of the reports that we have available that shows how, for example, in this case, a WHO Global Nutrition Policy report shows that infant feeding in emergencies is the least area of being acted upon by governments. It's the least area of action upon that the government have acted upon. So only, if you can go next, only 38 countries of the 165 countries have some intervention or some consideration in relation to have some protocols in relation to infant feeding in emergency. This is too little. This is really too little for us to be able to protect the breastfeeding and infant feeding of affected population by emergency across the world. Much more needs to be done. So there is a lot of work that needs to be done, and we have to do collectively. Next, please, and that will be my last slide. So I close with questions, and I'm sure some of the presentations will help us answer those questions. But really, these are the questions that we will keep pushing forward. We will keep advocating for answers with concrete resources. And basically, our question in relation to what will it take for governments to have policies and plans or protocols that includes infant feeding in emergency considerations. What action do we need to take, and this is for government and non-governmental actors, to invest in capacity development of emergency responders in relation to preparedness, response, and building the resilience, the coping mechanisms for our population? How do we increase our capacity to design responses, emergency responses, that can help us deliver effective interventions that will protect, promote, and support breastfeeding? These are big questions, but we will not stop asking those questions to our governments, and we shouldn't stop asking those questions. And again, I'm sure some of these answers will come out today, but let's continue advocating across all our governments for the protection, promotion, and support of breastfeeding and infant and young child feeding, also during emergencies. Thanks, Linda. Over to you.
Thank you so much, Alessandra, for this really insightful presentation and for leaving us with important questions to reflect upon. We will move forward now, and I'm also now delighted to present to you Paul Zambrano. Paul is a medical doctor with a master's degree in nutrition for global health from the London School of Hygiene and Tropical Medicine. He's more than a decade of experience in maternal and child nutrition, including humanitarian coordination. Paul previously worked in major emergencies in and outside the Philippines with Save the Children, WHO, and UNICEF. He was nutrition cluster coordinator and UNICEF health and nutrition specialist during the Rohingya refugee crisis in Myanmar in 2013. In his current role as regional technical advisor of Alive and Thrive Southeast Asia, Paul provides technical support to strengthen breastfeeding-friendly policy environments and health systems in Southeast Asia. He's part of the WHO Breastfeeding Evidence Group and is co-author of recent publications on the Code of Marketing, breast milk substitutes, maternity protection, human milk banking, and several others. Paul is based in Manila, Philippines. Paul will be walking us through experiences and learnings in IYCF and emergencies in Southeast Asia context. Over to you, Paul. Thank you.
Thank you, Linda, and thank you, Alex, for that great first presentation. I think it sets up my presentation and the succeeding ones very nicely. Next slide, please. And konnichiwa to all our Japanese participants and to all those who are not from Japan. A good day to all of you as well, and thank you for this opportunity. Before we begin, I would like to disclose first that I am an employee of Alive and Thrive in Southeast Asia, but I have no conflicts of interest to declare. In my presentation, I will be using the terms woman, mother, and breastfeeding, and individual parents and families may use different words, and I respect their preferred terminology. Next slide, please. So UNICEF in 2020 described the consequences of humanitarian crisis to the nutrition of children, adolescents, and women in very clear terms, as you can see in this slide. This description applies to all humanitarian crises, I would say, in any part of the world, regardless of the underlying hazard, whether it's natural or man-made or infectious, as in the case of the current pandemic. Next slide, please. And this is especially true in disaster-prone areas or regions of the world, such as Southeast Asia. It is one of the most hazard-prone regions globally and has suffered massive financial losses due to the consequences of natural hazards such as floods, typhoons, storm surges, and earthquakes. And of course, this effect is disproportionately felt by the poor and vulnerable within countries. And it should be said that within the region, of the 11 countries in Southeast Asia, 7 are currently classified as low to middle income. Now, I won't share and talk about all the experiences in all 11 countries, and I will instead focus on 3, starting with the Philippines. Next slide, please. So the Philippines is located in what's called the Pacific Ring of Fire and along the Pacific Typhoon Belt. And as such, my country rather, experiences around 20 typhoons a year. It could be 18, as many as 20 to 30. And of these typhoons, about 5 every year are considered destructive. The Philippines is the 9th most disaster-prone country in the world and 4th most at risk to climate change. But that's natural hazards. The Philippines, including especially in the southern island of Mindanao and certain parts of Mindanao, also experience chronic conflicts. So long story short, the Philippines is very hazard prone. Next slide, please. And the Philippines is a good case study because the country's policies to protect, promote, and support breastfeeding in both emergency and non-emergency situations has been described as world-leading. The Philippines is one of the countries to adopt and turn into national law the International Code of Marketing of Breast Milk Substitutes. It has 25 human milk banks, which are specialized facilities that are able to process and distribute donor human breast milk. In terms of emergency management, the Philippines uses what's called the cluster approach, which is a coordination structure that's used in many emergencies globally that allows the different sectors to do their own assessment of needs and to and to mobilize resources needed by all the organizations working within specific technical areas such as the health, water and sanitation and hygiene, education, and nutrition. But despite this, as Alex mentioned, unwarranted donations of breast milk substitutes are a perennial problem in the Philippines. Almost every major emergency experiences issues that are related to donations of breast milk substitutes, and it can be a very sensitive topic. And you can see in the photos to the right how this issue is portrayed in different ways in the media. Some reinforce government policies about not having donations, and some seem to portray the policies of the country as somehow being a barrier to humanitarian aid. Okay, and this happens year in, year out. It's a perennial problem. Next slide, please. So Alex described very well what the global guidance says about breast milk substitute donations and the risk of harm associated with this practice. But what does the Philippine government's policy actually say? And the good thing is, a lot of the Philippine policies are aligned with these recommendations. I'll give the example of Administrative Order 2007-0017, or Guidelines on the Acceptance and Processing of Local and Foreign Donations During Emergencies and Disasters, which says that infant formula, other breast milk substitutes, feeding bottles, artificial nipples, and teats shall not be items for donation. And the reason for this is what Alex presented earlier, that there is an inherent risk to these practices. But there is a second dimension to this that I hope I will be able to convey before the end of my presentation. Other policies, such as what were listed below in the same slide, reiterate this guidance and align recommendations with this guidance and the Philippines Code of Marketing of Breast Milk Substitutes, or the Philippines Milk Code. Next slide. And this is a good example. The Philippines DRM and Management Act of 2010 is a major legislation that reframed the whole the framework of disaster risk reduction and management in the Philippines, because again, it's a very hazard-prone country. And I won't read the whole text, but I can tell you that it highlights that in preparedness and response for any emergency, support to breastfeeding should be part of the package of response, whether it's by government, non-government actors, any stakeholder. And we see that from this that the Philippines recognizes the importance of breastfeeding in emergency settings, as aligned by the recommendations and global standards. Next slide, please. So in November 2013, Typhoon Haiyan hit the Philippines. It's one of the strongest disasters ever, typhoons ever recorded, and more than 4 million have been displaced. So because of the magnitude of the emergency, foreign aid was requested by the government, and the cluster system was activated, and initial assessments were conducted to determine the needs. Next slide, please. And the nutrition cluster of the Philippines identified these 3 initial focuses of the response plan: treatment of acute malnutrition, infant and young child feeding support with a focus on breastfeeding, and monitoring of breast milk substitute donations. Next slide, please. I won't tell you about all the details of the emergency, but there were challenges that were documented in the Haiyan response. One is the lack of national guidance, relatively, especially for non-breastfed infants. And number 2 and 3 relate to monitoring and identifying clearly the women who will be needing breastfeeding support, and those who have non-breastfeeding children or infants who will need different types of support. And number 4 relates to an essential component, which is skilled IYCF, or breastfeeding and complementary feeding counseling in affected communities. Note that these challenges do not say that formula donations were required but were not accessible, and they also do not say that no interventions were available for non-breastfed infants. Next slide. Because in Haiyan and in previous emergencies, the following have been done for both breastfeeding and non-breastfed infants. Mother-baby friendly spaces or similarly named structures were established to ensure that skilled IYCF counseling, psychosocial support, and other supportive services are needed by both breastfeeding and not breastfeeding mothers. For non-breastfed infants, these are also where wet nursing, relactation, and provision of pasteurized donor human breast milk is provided. Next slide, please. And these are photos documented by colleagues from KMI, Kalusugan ng Mag-ina. The left is a child who was separated from her mother but is being fed by a wet nurse. The photo on the right shows the mobilization of donated human breast milk that was pasteurized in one of the major hospitals in the country and sent to the emergency affected areas. Next slide. Again, Haiyan was not the first time that these interventions were in place. The photo on the left is breastfeeding in a context of management of acute malnutrition. The middle photo is one of the mother-baby friendly tents or areas in 2012. And on the right is a mother-baby friendly space that was established after Typhoon Sindong in 2011. This is an integrated service provision space where mothers are free to breastfeed, receive support, psychosocial support if needed. And oftentimes they just are a place for mothers to go and to feel safe, which is very important. Next slide, please. And Alex mentioned this, but I'd like to again emphasize that crisis marketing does happen and is a problem. In the COVID-19 pandemic, one of our studies showed that the violations of the Philippines Code increased substantially after the initial lockdowns due to COVID, and most of these violations relate to unwarranted donations of breast milk substitutes. Next slide. But just to say that the Philippine policies are a work in progress, more work is being done to more substantially align the current policies with the recommendations of the operational guidance on infant feeding and emergencies. Next slide. So from Philippines, we go to Myanmar. These are two examples of a similar space as I showed you earlier. This is an integrated space where mothers receive psychosocial counseling, breastfeeding counseling, where children are screened for acute malnutrition, where growth monitoring is done. And on the right are mothers with children with severe acute malnutrition, infants with severe acute malnutrition, more or less than 6 months, and breastfeeding is a pillar of that intervention. Next slide, please. And in the current crisis in Myanmar, because of the civil unrest, they are again being well coordinated in terms of activating the clusters and making sure that guidance is in place or updated to better support mothers in a complex type of emergency. Next slide. So I will end by sharing a quick experience in Vietnam, where the government of Ireland funded Alive and Thrive to support hospitals to cope with the surge of COVID-19 cases. So in these hospitals, the priority is for breastfeeding for women who give birth to receive the evidence-based package of interventions, early skin-to-skin contact, early initiation of breastfeeding. And in order to ensure that the healthcare workers are safe and that this practice is continued, then the government of Ireland donated personal protective equipment to ensure that the staff in these hospitals are able to continue with the best practice. And part of this is breastfeeding support that they were already doing but has to be continued, and to make sure that the pasteurized donor milk are available for vulnerable infants if they will need it, because these hospitals also have human milk banks. So the key message from this example is that it's donor action that clearly supports evidence-based actions for breastfeeding in a complex emergency such as the COVID-19 pandemic. Next slide, please. I think this is my last. So one of our challenges as humanitarian workers in nutrition is that often breastfeeding interventions and interventions for women who do not breastfeed are very underfunded in emergencies compared to funding that goes to food aid, that goes to establishing water sanitation and hygiene. And I think we need to do a bit more to understand that these are emergency interventions that are not only life-saving, but prevent long-term harm and also put children in a good position in terms of long-term developmental outcomes and even employment. We understand the economic benefits of breastfeeding a lot more, and they go into play in emergencies especially. So IYCF in emergency support, it's not only life-saving, but an investment in interventions that fundamentally support resilience at individual and at population level. And it will be great if emergencies from here on out in any part of the world that support breastfed, non-breastfed infants, and generally infant and young child nutrition will be well funded and will not have to face the similar challenge that we continue to have. So I think that's my last slide. Many thanks to all of you again, and over to you, Linda.
Thank you so much, Paul, for this really insightful presentation and for helping also in answering some of Alex's questions, and for the really illustrative pictures which help us visualize more the kind of support that is needed. So hopefully that was helpful in providing some answers. I now turn over to our next speaker, Carleen Gribble, which I'm delighted to present. Dr. Carleen Gribble is an adjunct associate professor in the School of Nursing and Midwifery at Western Sydney University. Her interests include infant and young child feeding and emergencies, obviously, regulation of the marketing of breast milk substitutes, and child rights. She has many publications in peer-reviewed journals on these subjects. She's a member of the steering committee of the IFE core group and has been involved in policy development, training, and advocacy in the area of infant and young child feeding and emergencies since 2006. Carleen passionately advocates for recognition of the importance of mothers to their infants and works to create environments that support breastfeeding and the mother-infant relationship, particularly in situations of adversity. She's also an Australian Breastfeeding Association community educator and breastfeeding counselor. I'll hand over to you, Carleen, to tell us about your experience in Australia and New Zealand.
Thanks so much, Linda and colleagues, and I'm so pleased to be here with you all tonight, talking about something that I'm very passionate about. And, you know, within Asia Pacific, we are not unfamiliar to emergencies, as Paul laid out. So next slide, please. So as following on from what Alex said, breastfeeding protects the health and well-being of infants everywhere. Often it's thought that breastfeeding isn't so important in wealthy countries with high standards of living, but that's not the case at all. So in research from Spain, they found that infants who were never breastfed were 7 times more likely to be hospitalised with infections than infants who were fully breastfed for 4 months. And in the UK, nearly a third of infant hospitalisations have been attributed to breastfeeding for less than 3 months, as compared to breastfeeding for at least 6 months. The difference between high-income countries and lower middle-income countries is that relatively few infants die because they're not breastfed. And the reason why that's the case is because we do rely on the clean environments that we've got for preparation and feeding of infant formula, and the easy access to safe water, power, infant formula, and healthcare. That's what protects our babies in rich countries. Next slide, please. But when an emergency occurs, that can change everything, because the infrastructure that we rely on to keep our formula-fed infants safe is often destroyed. And I've got an image there from the Earthquake Museum in Christchurch, New Zealand, which talked about, you know, taking things for granted, that simple things that were normally easy to do became extremely difficult when the earthquake happened. And the same, you know, that can apply to lots of things, but it absolutely applies to the situation of formula feeding an infant. So it's vital in emergencies that breastfeeding is supported and that proper support is given to the caregivers of formula-fed infants. Next slide, please. So I'm just going to talk a little bit about infant and young child feeding in emergencies in New Zealand in the context of the Christchurch earthquake. Next slide, please. So some background on infant feeding in New Zealand. There's a pretty high initiation rate, in fact, a very high initiation rate at 96%, but also high rates of formula feeding. So only 66% of infants are breastfeeding at all at 6 months of age, and very many infants are being mixed fed. And it is the young mothers, the mothers with low education and low income, who are the most likely to formula feed, and to stop breastfeeding early. And they're also the ones, just to keep in mind, who struggle most in emergencies. They're least able to leave, they're least able to get the resources that they need to do things differently after an emergency occurs. Next slide, please. So the Christchurch earthquake was at 6.3 magnitude, and it occurred on the 22nd of February 2011. Christchurch is a town with a population of 370,000, so quite large for New Zealand, not so large for Japan, but large in New Zealand. They had 80% of the city was without water after the earthquake, and 80% of water and the sewage system was severely damaged. And the big problem in terms of infant feeding was the impact that had on water quality. So the water supply was contaminated with sewage. There is extensive damage to buildings, roads, and services was severely disrupted. And the issue that they had around infant and young child feeding is that they didn't have any planning for it. So they were in a situation where there was nothing to guide the responders. Next slide, please. So what were the consequences of that lack of planning and inadequate response? Well, the welfare centres where families went for assistance didn't have any guidance on supporting infants. They didn't have any breastfeeding counsellors who were there, but they were handing out packs for families with tins of infant formula. They also had infant formula donations arriving in large quantities, and that they were just impossible to control. There were other problems with the donations, and this is very common in emergencies. You can see there the photographs on the right. On the top right there, that's a donation that was made by a company. They donated a product that wasn't approved for use in New Zealand. So it wasn't an approved product. The photograph on the bottom right there, you can see that was a donation of infant formula that was about to expire. And that is something that also happens very commonly in emergencies, where companies and businesses will donate expired or about to expire formula, which is a danger to infants. So nobody in this emergency was responsible for ensuring that parents who were formula feeding had access to necessary supplies. So infant formula was being handed out, but nobody was making sure that families who were using it had the ability to feed that to their babies safely. And they found, when they did a government survey, that some parents were using water that was contaminated with sewage to make up infant formula. And they had very distressed mothers and caregivers in this emergency who needed support and who weren't receiving it. Next slide, please. After the emergency, they decided that they needed to develop some planning for infant and young child feeding in emergencies, and indeed that is what they did. So you can see some of their plans there. They have the National Health Emergency Plan, which had an appendix dealing with infant feeding in emergencies. They had roles and responsibilities that were allocated to different people around support for infants, and that included things like, who is responsible for ensuring that formula-fed infants have their caregivers are being provided with the resources they need. And they also had some preparedness materials for parents so that they could actually have emergency preparedness for their babies around feeding as a part of their ordinary emergency preparedness, because they get earthquakes in emergencies and other sorts of emergencies in New Zealand from time to time. Next slide, please. So the situation in Australia now. Next slide, please. Our infant feeding practices very, very similar here in Australia as compared to New Zealand. So high breastfeeding initiation rates, high rates of formula feeding, the exact same rates of breastfeeding at 6 months of age. And you can see there on the right, though, that's the proportion of infants receiving infant formula in the last 24 hours by age, and very, very high rates of mixed feeding. And again, similar with New Zealand, it's young mothers, mothers with low education and from low income are the most likely to stop breastfeeding early. Next slide, please. So our Black Summer bushfires, they occurred from September 2019 to February 2020. 18.6 million hectares of land was burnt, over 6,000 buildings destroyed, and 80% of the Australian population was fire affected in some way. And that included my family. So we were very close to one of the very large fires and had to prepare to evacuate ourselves. We had over that period mass evacuations where large numbers of people were trying to escape on the roads that were blocked by just too much traffic. There were many towns with no power, water supplies were cut or contaminated, there were fuel shortages, communications were cut, mobile phones didn't work, towns were isolated, they couldn't get in or out of the town, supply chains were interrupted, and heavy smoke that made it very, very difficult to breathe. Next slide, please. And similar to New Zealand, we had no emergency planning for infant and young child feeding. And so this is actually some research that I conducted. I had been telling the government for a long time that we had a problem, that we didn't have planning. I don't think they really believed me until I went and got several hundred of our emergency plans and examined them in detail, looking for content on infant and young child feeding. And we really just have nothing. Next slide, please. So what were the consequences of that lack of planning and that poor response? Well, mothers having breastfeeding difficulties were not able to get support, and some of them shifted to formula feeding. And in the middle of an emergency is the absolute worst time to stop breastfeeding. Donations of infant formula were made and distributed inappropriately to breastfeeding women. You can see some donations there on the back of on the end of a pier, I think that is. Formula feeding parents didn't have access to the resources needed to formula feed with an adequate level of safety. Evacuation centres had no facilities for preparing infant formula or washing feeding bottles, and so unsafe formula feeding practices occurred. And again, mothers were very, very distressed and weren't getting the support that they needed. Next slide, please. So before I go any further, I just want to address the question of why breastfeeding women request infant formula in an emergency, because we talked about donations being a problem and that breastfeeding women might use them, but why do they do that? One of the biggest reasons why is because they believe that their milk is inadequate. And in an emergency, my experience has shown me that, that women, because they're very stressed, they think that that has interrupted their milk supply. It is not the case, but their babies become fussy and unhappy because their mothers are stressed and distressed. So it's their baby's behaviour that is telling them they have a problem with their milk supply. And so they ask for infant formula because they're worried that their baby is not getting enough food. Also, there is marketing that has led them to believe that infant formula is good for babies, and so mothers will request it because they think that this is a good product, that this will be a helpful thing, and perhaps they haven't been able to afford it before. And so if somebody is giving it away, they will ask for it. It can also be because formula feeding is normal for them, whether in their family or in their society, or in past experience, that's how they fed their babies. So that's why they ask to do it. It's familiar for them. So next slide, please. So what happens when mothers having breastfeeding difficulties get the support they need? So this is a good example. This is actually from the Victorian town of Mallacoota, which was very badly impacted by fire. And you can see what the sky looked like when the fire was around the town in that photograph. And Pam, she's somebody that I know. She was a Red Cross volunteer, and she was flown by helicopter into that town the day after the bushfire had swept through. She was there with the Red Cross to help set up an evacuation centre. But fortunately, Pam was also an Australian Breastfeeding Association breastfeeding counsellor, and so she found herself providing breastfeeding support to many mothers. The mothers there were very stressed and distressed. Their babies were wanting to feed very often and didn't want to be put down, and they were coming on and off the breast. And these mothers were worried that stress had reduced their milk. But Pam was able to reassure the mothers that their milk supply was fine. She spoke to them about how babies were feeling unsettled by the unfamiliar situation and how they found comfort and security in breastfeeding as well as food. And that's why they wanted to feed more frequently. She helped them to understand their baby's behaviour and have confidence to keep breastfeeding and protect their babies. But it was pure luck that Pam was there to help them, because there was no plan to have anybody there to help mothers with the breastfeeding of their babies. Next slide, please. So, but what happens when the support isn't there? And so this is a situation, this is a true situation that happened as well. This was in New South Wales, on the New South Wales South Coast. But this mum had a 3-week-old baby. and she'd had to evacuate her home because of the fires. She'd been exclusively breastfeeding, but the emergency was stressful and her baby was fussy. And Olivia, this mum, thought that she had a problem with her milk. She got some milk. She went to the evacuation centre. They had the formula on the table. She could just go pick it up and take it away, and that's what she did. But the town water supply was contaminated, and even though they had a boil water order in place, so people were being told to boil the water, but there was no electricity. And Olivia didn't have a gas stove to heat water, and there wasn't any to buy in the shops. She fed her baby as best she could, but she and her baby were failed. She needed breastfeeding counselling so she could keep breastfeeding her baby, and giving her infant formula without ensuring she had the ability to safely prepare feeds was negligent. That should not have occurred. That poor infant and young child feeding response placed her and her baby in danger. Next slide, please. So emergency planning and response must address the needs of breastfed and non-breastfed infants, as well as complementary feeding. And you find all of that in the operational guidance for infant and young child feeding, which is on there on the right. Next slide, please. So why is breastfeeding counselling good? It enables mothers to continue breastfeeding like it did with Pam, with the mothers that she helped. As I said before, breastfeeding counselling can help mothers to understand their baby's behaviour and be confident to keep breastfeeding. On the left-hand side there's a paper that actually describes how somebody did that in New Zealand after the Christchurch earthquake. It wasn't planned, but somebody was able to put everything together to make it happen anyway. Next slide, please. And properly managed infant formula support protects both breastfed and non-breastfed infants. In an emergency, infant formula should be treated more like a medicine than a food, distributed with great care, ensured that caregivers had everything they need to protect their babies and feed them safely. Where infant formula is requested, you really need to have an appropriate qualified health worker do the assessment. Next slide, please. An absence of proper support for non-breastfed infant places the non-breastfed baby and breastfed infants in danger. And you can see on the left-hand side, this is in Christchurch. People want to do something to help. And so there they've got some infant formula that they've gotten together just to hand out to anybody. But if you've got proper support for formula feeding, people know they don't need to do that. Families can be directed to that proper support, and that's what protects their babies. On the right-hand side, there's a paper just recently published in the last month by myself, describing, what you need to do in order to have good practice in infant formula distribution. Next slide, please. So even in the wealthiest of countries, infants and young children are vulnerable in emergencies and are in need of targeted and appropriate support. Breastfeeding should be protected, promoted and supported as the best emergency preparedness for infants, and we should be telling mothers this. Next slide, please. Just some references there at the end. I think I've gone over time, but you should have access to those after the tonight if you would like them. And I'd just like to thank everybody for being here tonight for this meeting.
Thank you so much, Carleen. And I think it is timely to actually ask the next poll, which really is asking about the preparedness plans and the IYCFE preparedness. So if I can ask my colleague to launch the poll and to get an estimate on emergency preparedness plans within your country that include provisions for infant feeding. Given the importance of this step and what Carleen highlighted, it would be good to reflect on this within our own countries, as evidence has been presented on the importance of having these plans. So we will wait for a few more seconds until everyone has the opportunity to answer this poll, and we will now close the poll. I'll take the opportunity just to ask colleagues who are raising their hands to please use the Q&A box to ask their questions. So from the results of the poll, we can see that 33% have answered yes to having provisions for infant feeding, 12% no, and 55% I don't know. So I think that by itself is a good indication that it would be good for us to look into the existing emergency plans. Thank you so much. I will now move to our final speaker, Jodine Chase, and I'm also delighted to present Jodine, who's a public relations and communications consultant specializing in issues and crisis management news analysis. Jodine is a co-founder of Safely Fed Canada, which is a national nonprofit, nonpartisan organization dedicated to the protection of infants and young children in emergency through safe and appropriate feeding. Safely Fed Canada advocates for improved infant feeding policy federally, provincially, and locally, designs and delivers training and coordinates direct aid to families in emergencies through our staff, volunteers, and partner organizations. Jodine is a longtime breastfeeding advocate who, as a volunteer, has worked for many breastfeeding-related causes, including advocating for the reestablishment of milk banks, amending policies and legislation to protect breastfeeding rights. Jodine will be presenting the experience related in Canada in Fort McMurray wildfire. The floor is yours, Jodine.
Thank you, Linda. Thank you for that introduction, and thank you very much for having me here to speak about our experience in Canada, specific to one particular emergency in 2016. Next slide, please. So I will briefly disclose that I have no conflicts of interest to disclose, and that portions of the project that I describe here in this case study were funded by donations from across Canada and administered by the Canadian Red Cross through the Fort McMurray Wildfire Recovery Community Organization Partnership Program. Next slide, please. So just to give you a brief sense of the situation that I'm going to be discussing, you can see on the left the area that is impacted by this disaster is the area around the city of Fort McMurray in Alberta in Canada. This is quite a northern city, not very far from our Northwest Territories border. It is isolated, surrounded by forest, and about 400 kilometers from our closest major city, which is Edmonton, which is where I live. I'm going to be looking at the situation today, the response, what the learnings were for us, and also some of the outcomes and new programming that has been put into place. Next slide, please. So this was a very rapid, large wildfire that came on the city of Fort McMurray, which has a population of about 88,000, 75,000 who live there regularly, and often between 10 and 20,000 workers come in and out of the city to work in the oil sands, which is Fort McMurray is the center that supports oil sands production in Canada. It was an interface fire. There were 2,600 structures destroyed. The entire city was evacuated with almost no notice. So about 2/3 of the population fled south on the only road out that leads to other centers. They were almost all driving. And about 1/3 of the population fled north, what they call the highway to nowhere. It's not really to nowhere, but it does end only a few kilometers north. And they fled to a very small Indigenous led community, Fort Mackay, plus into work camps, which are work camps support workers that work in the area. They're like hotel-like structures. Some of them were open and operating, and some of them were closed. That population that fled north, the wildfire took quite a number of weeks to bring under control. So that population had to be air evacuated out of the area. Next slide, please. So during that evacuation, of the population in total, about 3,000 were under the age of 24 months, and that included about 900 breastfed infants of all ages, from newborn through to older toddlers. Just for a little bit of background, this community at the time had a very high birth rate for Canada. It was supporting about 125 births per month at the time of the wildfire. Next slide, please. So knowing the challenges within this community and prompted by the arrival of tens of thousands of people, mainly into my city, but also into the communities in the surrounding area. We worked with a group of volunteers from a number of organizations and mounted a response to support these families with these young infants. We were guided by the Infant and Young Child Feeding in Emergencies Operations Guidance. Next slide, please. Now, the guidance outlines a number of steps, and one of the very first ones is to assess the situation and to monitor the situation. So we conducted some early assessments. We relied on data that was available to us from the Fort McMurray Public Health Baby Friendly Initiative. And we received phone calls from people who were part of that initiative who were evacuating to tell us urgently and remind us that although the area has quite a high breastfeeding initiation rate, at the first home visit or the first contact with healthcare workers after people have been released from hospital after birth, there's already a 54% formula or mixed feeding rate. And so you have a very high rate of people who very quickly have shifted from breastfeeding into mixed feeding or formula feeding. So we found in our assessments of both the situation and the evacuation centers where people were being housed temporarily, during and immediately after the evacuation, there was a significant influx of infant formula. During this evacuation, there was absolutely no shortage of infant formula in our province, but we received many, many donations. And on the photo on the right, you can see this is in one small town that's several hundred kilometers south of Fort McMurray, where people arrived. It was for many the first place they could stop after being on the highway for hours and hours in congested traffic as people tried to leave. And they walked into this small town's gymnasium, and there were many, many tins of donated formula that had been set up on arrival. So we also had a lot of, as Carleen had noted, in Australia, where there was no plan to support the specific vulnerable population of infants and young children. People just support as best they could, but they don't often think of these needs. And so there was much breastfeeding that was occurring in unsupportive and inappropriate places. And also preparation of infant formula was happening in inappropriate and dangerous places. The very largest evacuation center had preparation occurring in washrooms. And unfortunately, that evacuation center was hit shortly after people arrived. It served about 20 to 25,000 people in total, and they had a significant gastro outbreak. And so infant formula preparation was happening in the same washrooms that were being used by people experiencing the impacts of that outbreak. We also found mothers attempting to breastfeed very small infants where they could. So frequently mothers were in washrooms sitting on the toilet, which was the only place they could find that was private to sit down and breastfeed their infants. Next slide, please. An important step in supporting populations that have been evacuated to feed their infants and young children safely is to register households so that you can identify their numbers and their needs for support. So on the left, here is a photo of one of the registration centers that was set up to support this population. This is very typical in my country, where you have a large, we call them sometimes reception centers or registration centers, large lineups where the entire population waits to be registered so that they can be identified as in need of support. On the right, here's another photograph that shows where we did see some excellent triage as the people who went north had to be airlifted. They did prioritize the needs of the population that had just birthed. Many of them were evacuated from the hospital into this northern area, and also young families and infants were flown out first and taken into congregate housing in other cities. You can see also just a little bit of the photo on the right. This is a very typical example of what the evacuation looked like for most people. It was very orderly, but it was slow. Their highway did not have enough capacity to support the entire evacuation. And so people were in those cars for many, many hours. And many of them in the early few minutes of their evacuation, as they were fleeing, they definitely feared for their lives. There were flames licking the sides of the road in many cases. So next slide, please. So that last slide, I just want to let you know too, is a reminder of how important it is to assess the needs once people are arriving into a reception center where you may need to house people for a period of time. On the left, this is a very typical example of what the shelters look like. You can see they're efficiently organized, but they're also vast. For families with very young children or infants, they're crowded, they're loud, and there's not usually any attempt made to support or segregate families who have young children into a special area. They're in the general population. So very quickly, one of the other organizations that worked to support this population was Save the Children, and they realized that there was an important need to support families, and they began setting up child-friendly centers. And then they passed on to our organization their responsibility as best we could to support infants and young children within that setting. Next slide, please. So another intervention is to ensure appropriate, safe, complementary feeding. What we noticed in many places were that toddlers were being provided with drinks that are promoted or advertised as being very healthy and important nutritional drinks. They're actually sugary drinks like chocolate milk, and this was a concern. So when we raised this concern, the food services people who were supporting the population did bring some fresh fruits for the young children. Next slide, please. We did a very significant piece of work. We helped whenever we could. We rapidly assessed the needs of anyone we saw with an infant or a young child, and in that we found that we asked three basic questions. How old is the baby or child? How did you feed the baby or child before? And how is the baby fed now? And the answer to that question helped us to support families. But we also noticed from the data we were collecting that exclusive breastfeeding dropped very significantly from before the evacuation and into the first couple of days. So we see exclusive breastfeeding went from over 25% to well under 20. And you can see the shift in these statistics as families moved from exclusive breastfeeding to some breastfeeding. So they introduced formula or other foods. And then those who were mixed feeding moved very quickly, rapidly to only formula feeding. Next slide, please. So all of these learnings where we found, the overwhelming response to calls for donations in my country, where people were very generous, did include a lot of powdered infant formula and inappropriate and sometimes dangerous donations of products. There was definitely a lack of understanding of the infant and young child feeding in emergency needs amongst all of the responders, part of people who were paid and also volunteers who responded. There was really inadequate support at reception sites for these evacuees. And especially for those with children who either needed to receive breastfeeding support or simply just needed quiet places to breastfeed, and also people who needed to prepare infant formula. And like Carlene has said, and others have illustrated, like many high-resource countries, Canada has few or no policies related to infant feeding and disasters. Next slide, please. So from our learnings and through this project that was funded from the donations that were received for the community, we worked with the local authorities, their emergency and social services responders, the public health authorities, and community partners. We did training, sensitizing, and orientation on what infant and young child feeding in emergencies is and what it should look like. And out of that, one of the very important incomes for our country was the development of our country's very first baby child unit as a documented policy and procedures piece as part of the emergency support services that we deliver in our country when people experience disasters and have to be evacuated. And that work was measured using pre and post-training questionnaires and we modified the World Breastfeeding Trends Initiative Global Indicator on IYCFE in order to measure this work. Go ahead and to the next slide, please. So some of our training tools, this is an example of how we actually took work that Carlene and her colleague developed to identify exactly what it takes in terms of supplies to support one infant during an emergency over a period of time. For us, it's 72 hours. And we would show the small amount of supplies, which is what you see on the left, that are needed if you're running an evacuation center to support a breastfed infant. And then we show the large amount of supplies for one infant that is needed to support an infant that is fed with infant formula. And we actually would set up these displays during our training because the act of carrying in all of these supplies is really an illustration, especially the heavy jugs of water that you can see on the right, of the amount of work that it is going to be to support a family if you have disrupted their breastfeeding in your response. Next slide, please. So another training outcome was that we introduced the idea, we exercise disaster plans in our country, as many of you also do. We made sure that actors who participate in those, there are scripted to be family members, so caregivers with babies and young children. And we even at one point introduced some children into a disaster exercise. Next slide, please. And that helps planners actually understand what their gaps are. If you have someone who shows up role-playing a parent with a child needing to change a diaper or feed a baby, it really helps the emergency responders see what the gaps are. So the outcome here was the development of the baby child unit, which creates a safe space for care for children and caregivers in emergencies, addresses the specialized feeding support that is needed and the hygiene needs for children under the age of 2. And it's important to stress that this baby and child unit does not provide childcare. It supports the caregiver and the child together. Next slide, please. Some of the priorities of the unit are nutrition and hygiene, also sleep and support for families. And this unit registers families within this setting, so they no longer have to line up in a large general registration area. And there are also other pieces of this signage that supports evacuees to direct them away from dangerous practices, such as preparing in washrooms and towards these specialized areas that are set up. Next slide, please. And so I'm going to end my tale about our story by reminding you that many of our countries do not have adequate policies in place. And my country, Canada, is one. So this is one tiny program that is actually within a country where we have very few supports for IYCFE. I'm going to show you some information now from the World Breastfeeding Trends Initiative. In particular, you can see in Europe, of the 18 countries that have done the initiative scorecard for breastfeeding supports, the lowest score or the lowest response is in IYCFE, and that holds across the globe. And countries like mine, we haven't done this indicator, but I can tell you if we did, we would score 0. Other countries like France, Germany, the UK, and the US have all scored 0 on their IYCFE piece. And so for us, really, once you know how important IYCFE is, it is important to begin asking those questions in your own country. What are our policies that are in place and our procedures, and what can we do to improve those situations? Thank you very much for the opportunity to present. Like Carleen, I have some references which can be made available to you later.
Thank you so much, Jodine. This is really insightful. And you've also emphasized the importance of emergency plans, but you've also provided some very concrete examples of how you can support during emergencies and create those friendly spaces and provide and do the assessments, the one-on-one, and also artificial feeding support. I think with that, we wanted to kind of really summarize some of the things that all of our panelists have emphasized, and really fantastic experiences that we hope that have helped shed light on the importance of IYCFE and ways to make a difference in infants and young children's lives. It is really time to act. And the Nutrition for Growth Summit is our chance. It's the chance to act and provide this support. So we wanted to take this opportunity to call on you to pledge commitment to infant and young child feeding in emergencies as an intervention that fundamentally supports, as Paul mentioned, resilience and food security. So therefore, we do have some suggested calls here, and the first of which is really to invest and to fund the actual protection, promotion, and support of infant feeding practices for all mothers caregivers and their infants and young children at all times and in all contexts, to consider including concrete actions and resources that are needed to protect, promote, and support infant feeding in emergencies. We saw preparedness, response policies, recovery and resilience plans. To adopt and implement the code, the International Code of Marketing of Breast Milk Substitutes, and the operational guidance as instruments that can help you protect mothers, caregivers, and children. Importance of building the capacity, how each of us can contribute to building their capacity and the capacity of the actors in emergency and humanitarian responders and their agencies for the protection, promotion, and support of infant feeding during emergencies. And wherever we are, to raise awareness around us across all the population on the importance of protecting and supporting infant feeding practices during emergencies. So throughout the presentations, colleagues have shared some really useful resources. So we wanted to concretely, link you to some of these ways you can contribute and really understand more and raise awareness about infant and young child feeding in emergencies. So all of the speakers have mentioned the operational guidance. It is available in several languages. I'd also like to shed light on some of the visuals, infographics on infant and young child feeding in emergencies that you can find on the IFE core group page. Other resources that can help with, number one, the breastfeeding counseling, providing breastfeeding counseling in emergencies, how we can do that. And number two, if we're working on artificial feeding support, what are some of the guidance on procurement of breast milk substitutes based on the UNICEF programming guidance. I'll hand over to Hiroko also to share with us some really useful Japanese resources.
はい、このどうする災害時の赤ちゃんの名誉の漫画のオリジナルは先ほどから紹介のある災害時の手引きをもとに日本語で作成されました。で、現在8の言語で ENN のサイトからダウンロードできます。次お願いします。はい、次は日本語の資料ですね。これらも様々な日本語の資料もありますのでお使いください。はい、次お願いします。はい、こちらは日本語に翻訳された資料になります。今回紹介された英語の資料でここで日本語で翻訳されていますのでどうぞお使いください。次お願いします。で、最後にWHO コードについて少しだけ補足します。何度か代替品のコードという言葉が出てきたんですけれども、この WHO の母乳代用品のマーケティングに関する国際基準は、すべての赤ちゃんの命と健康を守るために、母乳代用品の宣伝や販売促進を規制し、必要な場合には安全に使えるようにするための国際的な約束です。で、国際基準はなぜ必要なのでしょうか。それは母乳が出る仕組みを守るためです。それから赤ちゃんがおっぱいから飲む意欲を守るためです。そしてお母さんの自信を守るためです。情報やサポートはミルクを必要とする赤ちゃんのためにもとても大切です。そして国際基準を守るのは企業、私たち、みんな支援者たち、そして行政、政府です。では、リンダさんにまた進行してもらって Q&A セッションに移ります。
Thank you, Hiroko. I think it's also an opportunity for us to ask the audience about the code. And so I'm going to just ask our colleague to launch the poll on the code and just to see quickly information about countries who have legislated the code. So if we can please launch that last poll so we can have this quick kind of information. Are we okay with the poll? I can't see it. Yes, now I can see it. So if you could please answer this question, whether you know whether the WHO International Code of Marketing is legislated in your country. We'll give it a few seconds, and I can see a lot of no's on the answers. So hopefully also this is a call to work on implementing and legislating the international code in our countries, as it is really a main way to protect breastfeeding and infant feeding. So we can maybe end the poll now and see the results. We can see that only 8% said yes with full provisions, 13% said yes partially, and 60% said no, and 19% said I don't know. So thank you so much for this. I think we can now move to our final part of this session, and really it has been really fascinating listening to the presentations. I know there has been some questions in the Q&A box, and colleagues from the panel have answered those. We also received questions from the forms. So I'm going to ask one of the questions that have been received within the registration, and which was the following: the method of uniform distribution of liquid milk stockpiled by local governments for disaster use in disaster areas, and the methods of rolling stock, such as distributing stockpiled milk to the general public before it reaches its expiration date, are in conflict with the WHO code. I would like to hear the opinions of experts from other countries on this. I'd like to give the floor to our panelists to answer this question. I think, Paul, maybe I can call on you. Is that okay?
Hi, Linda. Thanks. Thanks for that question. It's a long question, and there's quite a bit to unpack. I think let me address it this way. I hope I make it simple, but also address the important points. So as emergency responders, as I've been for most of my career, well, we're often made to feel that the code stands in the way of emergency response. Like if you stop donations of formula, you are stopping aid, but it's actually the opposite. So in my presentation, I wanted to share with the audience what's actually being done for both breastfed and non-breastfed children, and unwarranted donations of formula undermines this. So the two dimensions, one is we have a package of standard evidence-based interventions that we need to do and are being done, and we need to continue to protect that. For children who will need artificial feeding, and there are, the operational guidance and other standards are clear in how this should be done safely, sustainably, and for as long as they are needed. And to not do it that way, it's not in conflict with the code. It's in conflict with the principle of do no harm. Because as Alex mentioned, there is a risk to doing this if it's not according to the standard. So, and with this issue of crisis marketing, they certainly can be done in a way that markets breast milk substitutes. And we know that there's another layer of harm that results from this marketing. And it's marketing that the code is trying to stop. It's a code of marketing. Let's emphasize that the code does not prevent access to breast milk substitutes when if they are needed. It has nothing to do with distribution and sales. It's about marketing. But we do have the humanitarian standards that tell us how to do artificial feeding when indicated safely and sustainably in a way that doesn't do harm. So I hope my approach is able to answer that question, because we often immediately try to think of justifications for infant formula when we all need to probably be more familiar with first what is the broad range of interventions in place and the basis for that. Back to you, Linda.
Thank you so much, Paul. Any of the panelists would like to feed on that, or I can move to another question? Let me know.
I'll just jump in really quickly, Linda, to let the people that asked the question know that we just addressed that question in the local context here in our area, and the decision was made not to stockpile. It was decided that that was a much too complicated and concerning approach, and that they would focus efforts on supporting the population is resiliency through breastfeeding support, and also education around the need to appropriately prepare the existing formula that is available and could be accessed during an emergency.
Thank you so much, Jodine. I'm aware you have time. We do have maybe time for one more question, and maybe I can ask Carleen. There was a question about supporting mixed feeding and how to support infants who are mixed fed. Would you like to reflect a little bit on that?
Of course. Yeah, I mean, infants that are mixed fed are in they're in a much better position actually than infants that are fully formula fed, because it is possible for women to increase their milk supply in quite a quick time if that's the case. And the problem comes because very often at the very beginning of an emergency, there can be some delay in infant formula being available. And so that's where wet nursing can come in. And even in places where wet nursing is not something that is practiced traditionally, in emergencies, women are willing to do that, and they do it. So in Australia, it has happened in our emergencies. In New Zealand, it's happened in their emergencies. So, and the goal is with mixed fed infants to actually move them from mixed feeding to exclusive breastfeeding in an emergency, just because it protects them so much better. So again, that does come down to having breastfeeding counselling. I did notice, Linda, there was a question in the chat box that I wanted to answer but wasn't able to type in for some reason. Yeah. And somebody had, and it kind of hooks into to what Paul was talking about earlier, and that was somebody had said at their university that they'd learnt that infant formula has some nutrients which isn't in breast milk, and asked whether that would mean that we shouldn't use infant formula. That sort of idea is very commonly taught, unfortunately, to health professionals and also to students. And what that is reflecting is actually unethical marketing. So it is very, we've talked in this meeting a lot about the protection that the WHO International Code provides. And what it provides is protection against that sort of unethical marketing, which tells lies. So unfortunately, a lot of education that health professionals receive will tell them that infant formula is better than breast milk, that there are deficiencies in breast milk, that there are special ingredients in infant formula. It is all lies. And so, when I talked earlier about mothers requesting infant formula, sometimes it can be because they have believed the marketing that has told them that the infant formula will make their babies smarter and will protect them against infection. In fact, the opposite is the case. Infant formula impedes brain development. It makes babies more vulnerable to infection. And that's why we're so keen on protecting breastfeeding and providing really good support to formula-fed infants, because they are really vulnerable in emergencies because they're formula-fed. The more babies who are breastfed before an emergency, the better the situation is when the emergency occurs. So putting support around breastfeeding prior to emergencies is really important as well.
Thanks so much, Carleen. And really, this is an amazing reminder about the importance of, as you say, supporting breastfeeding in non-emergencies as the ultimate preparedness. I think we've come to the time of closing. I would quickly like maybe to ask our panelists for any final words before we close. Carleen, anything to add, or shall I move? Well, good. All right. Alex, any final words from you?
Yeah, first, thank you to all my colleagues here and to the participants. Really, I think the key message for me, and again, I always learn as well through this conversation, is we need to invest in women and their children. I think that's one thing, regardless of their feeding practices. And I think that's also very important, but we need to invest and provide all the support that they need before an emergency and unfortunately during an emergency. I think that's, and our governments have a responsibility to do that. So not to say more, but really we need to keep in mind that yes, women can breastfeed if supported, but we need to provide the conditions. So I think in a separate talk, we were discussing about ensuring that breastfeeding support is in the workplace, ensuring that breastfeeding support is in the public places, is in our health system. So we need to create a culture of support to women and their children. And we have the responsibility to do that. So I want to emphasize that women are not, it will not be able to do so without that kind of support. We'll always have problems if they don't receive that kind of support. So resilience, preparedness, and so on and so forth. The last thing is government should look at breastfeeding as the solution, not infant formula as the solution or the easy solution. We need to invest because breastfeeding will eventually be the solution. And I think our speakers have confirmed that through the experiences. So again, thank you so much. Over to you.
Thank you so much, Alex. Jodine?
I am not sure that there's anything that I can add to this other than to remind everyone that the act of supporting breastfeeding is an emergency preparedness activity.
Exactly. Thank you, Jodine. Paul?
Breastfeeding is a collective social responsibility, and that does not change even in an emergency setting. I would say even more during emergencies where existing vulnerabilities are compounded by even more vulnerabilities. So that does not change. Yeah. It's still and will always be a collective social responsibility.
All of us, our responsibility, each member of the community, as you say. Yes, thank you so much. So I think hopefully we had the chance to reflect on infant feeding in emergencies and share these learnings, and hopefully we have had a slight contribution to really encourage you to think more about emergencies and infant feeding and mothers and caregivers and preparedness. I wanted to remind you that all the questions that you have asked will be answered once you receive the link to the Zoom recording. You also will have the opportunity to have the recording. I think Hiroko now will give us a bit more information on that. But if you have other questions, I wanted to also flag that there are two links here that will be shared in the chat. One of them is NNET, which you can actually ask for peer support. And the other is the GNC Technical Alliance, where you can actually ask for individual support. And with that, I wanted to thank again, first of all of you for this amazing participation and for sticking in for a few minutes after the end of the webinar. I also want to reiterate my appreciation to colleagues who've helped with organizing, of course, IFE Core Group, Safely Fed Canada, Alive and Thrive, the Infant and Young Child Feeding Support Network in Japan. Also grateful, of course, for the support of ENN, La Leche League Japan, Japanese Association of Lactation Consultants, and Breastfeeding Support Network of Japan, and Save the Children Japan. And of course, grateful for the support of the members of the IFE Core Group and that of USAID and Irish Aid for their support for the IFE Core Group. With that, I thank you so much, and I hand over with a final word to Hiroko.
はい、最後の言葉と言いましても、本当に皆さんありがとうございました。こちらの右側に2次元コード、QR コードがあります。それからチャットの方にもURL を出しておきますけれども、どうぞアンケートにぜひご協力ください。で、アンケートに書いていただけますと、本日の資料がダウンロードいただけますので、どうぞアンケートにご協力ください。 よろしくお願いいたします。どうもありがとうございました。
Thank you so much. Wishing you a great rest of the day wherever you are. Thank you so much for the panelists.
Arigatou gozaimasu.
Bye bye.
Thank you.
Thank you.